So at our transplant center, we really have a multidisciplinary approach to patient care, and I think that really leads to the best outcomes. One of the important things we do is really try to educate our patient before they're ever transplanted so they understand what they need to do and so they have the best outcomes. And I think we really have a great team approach, so we have surgeons who are expert at what they're doing, and then we also involve the medical discipline early on. So we ensure that they have their hypertension well controlled, all their comorbidities that led them to need a transplant to begin with. We have a team of physicians and nurse practitioners who follow them afterwards. And I think that really allows us to take good care of them, recognize problems early, address them, and hopefully achieve the best outcomes we can for our patients. Well, the pathologists are critical, especially as transplant has become more complex with highly sensitized patients. We really need them to help us. So I would say it's a team of our tissue typing lab, as well as our pathologists, as well as the clinicians who take care of the patients. And we meet at least on a weekly basis where we review all the difficult cases and we come up with a treatment strategy to understand what those patients have, a treatment plan in place, and then how we monitor them so we get good long-term outcomes in them. Sure. So the Elevate study was really an interesting study. It really had good long-term follow-up. It was about 24 months, and patients were randomized after about 3 months to continue on a calcineurin-based regimen with mycophenolate versus tacrolimus as the calcineurin base and everolimus. And then it looked at those patients at 24 months. And I thought the interesting part was looking at their histologic findings. So in that study, they had decreased interstitial fibrosis and tubal atrophy, what some people would have called in the past chronic rejection. So I think there was good histologic evidence that they had less worsening of chronic allograft nephropathy or chronic damage. There was an increased incidence of acute rejection, and I think anytime you have a conversion study, I think that's always a possibility. And I think you take one group that remains on a well tolerated and effective regimen, and you're changing them to an unknown regimen. So although there was increased rejection, I don't think that it was numerically so dramatic that you should not consider converting patients to let them achieve good outcomes in the long term. Well, in this study, all the details weren't known, and I think we have to wait for eventually for the paper to come out or more abstracts to be presented. And the authors didn't have time to get into everything with the study, but appeared that they were stable patients. And I think it was at 10 to 12 to 14 weeks, I think they were converted. So I think you would just look for patients that have done very well with very stable function, and they're compliant and they're able to achieve close monitoring. I think that's really paramount, is whenever you convert someone, you can't just assume they're going to do well. You need to have sort of that heightened monitoring again for the next 2 to 3 months. Well, I think the US 92 in some ways complements the Elevate study. And so what that study showed was that I believe it was a 12-month study, and patients were again randomized to tacrolimus mycophenolate-based regimen, and half the patients were then converted to tacrolimus everolimus. And then they looked at those patients to see how they did really in a short term, with 12 months, not very long term. And I think what that showed me, and the authors demonstrated, was that you need to have reasonable levels of both agents, both tacrolimus and everolimus. And the patients who had everolimus levels less than 3 or tacrolimus levels less than 2 had a very high incidence of acute rejection, much higher than those who achieve sort of what you want in your goals of levels about 3 to 8 for everolimus, and I think around 2 to 5 was the goal range for tacrolimus. So I think when we talked about which patients can you identify that may not do well when you convert them, you may not always be able to identify who they are, but I think you know that you have to achieve good therapeutic levels and monitor those patients very closely. So they weren't really able to demonstrate convincingly that there were more side effects of one regimen versus the other, because I think the data didn't really allow us to achieve good conclusions. And I think the authors, what they stated was, you really just need to achieve levels within those ranges to get the best long-term outcomes. Again, I think there were more rejections in the conversion group, but again, I think that's what you would expect. And I believe that they showed there was less graft loss in the patients who were on the everolimus-based regimen, despite a higher rate of acute rejection. I think those are, for people who use the mTORs on a routine basis, I think those are well known. I think as more and more physicians and practitioners are using the mTORs, I think they need to understand there are predictable side effects. Those are typically going to be hyperlipidemia, delayed wound healing, potentially higher rates of lymphoceles, stomatitis, I think, occur in a certain percent of patients, as well as sort of a capillary leak syndrome, peripheral edema. Those are typically manageable, and I would say in my experience, which is fairly extensive, that tends to be dose dependent or level dependent. So certainly when you start to achieve levels beyond the therapeutic range, and even the high therapeutic range, you may have patients who experience those adverse outcomes. Honestly, most of the time it can be managed, and we have a very low rate of conversion away from the mTORs. Other people have lower thresholds, and they may convert them back to some other regimen. I think that there was a study showing improved renal function at a relatively short duration of about 6 months, but there have been many studies showing that an mTOR-based regimen does have improved renal function in the medium to long term. And I think that, combined with the Elevate study that showed decreased interstitial fibrosis, would suggest to me that you can achieve better long-term outcomes with improved renal function in the medium to, probably at least in the medium to hopefully long-term, histologically and clinically in a meaningful way. And I think an mTOR-based regimen is certainly something that should be strongly considered in all of your patients. Well, I think there continues to be the difficulty of managing humoral-mediated rejection, and I think there's some interesting agents that are being placed in trials, but I think the whole field is really struggling with what's the best way to treat this very difficult group of patients. There will be more highly sensitized patients coming through due to the kidney allocation changes, and I think as a discipline, we need to have good studies to ultimately achieve what the answer is to that problem.